I'm Dr. Alana Yurkiewicz, and this is Hard Medicine. Primary care is supposed to be the front door of the healthcare system, the place where you're known, seen, and guided over time. But for millions of people, that door is effectively glued shut. You know it when you try to get an appointment and there's nothing for 3 months, or when you see someone different at every visit, or when your doctor stares at the screen instead of you. It's easy to blame the person in front of you. The harder truth is that modern primary care is not built for the job it's tasked to do. Behind the scenes, primary care doctors care for practice sizes so large no human mind can hold them. We are asked to deliver relationship-based care through a transactional payment model that only rewards appointments and no communication in between. We answer an avalanche of uncompensated messages and electronic chart work that didn't exist a decade ago. The result is a profound mismatch between what primary care requires and what primary care doctors are given. It means that primary care doctors are overworked while simultaneously unavailable. It means the outcomes we see are not an unfortunate byproduct, but the direct result of the structures we have. My guest today understands this better than almost anyone. Dr. Lisa Rotenstein is a primary care physician, researcher, and medical director of ambulatory quality and safety at UCSF Health. Her work quantifies the pressures inside the system, the real hours primary doctors work, the burden of electronic medical records, and the consequences nationwide. She calls what's happening now unsustainable, and it threatens one of the only parts of American healthcare that consistently improves outcomes: strong primary care. Dr. Lisa Rotenstein, welcome to Hard Medicine.
Thank you for having me. It's a pleasure to be here.
I want to start with the good. Arguably, no one understands the problems of primary care better than you. Yet you became a primary care doctor, and you remain one, even as you research and publish on all of its problems. What drew you to primary care, and what keeps you in primary care?
I'll tell you a little bit about when I first became exposed to primary care. It's similar themes and principles that keep me interested in primary care and enjoying primary care all these years later. So when I grew up in Southern California, and when I was in high school, I worked at a free clinic called the Westminster Free Clinic. And we took care, or I volunteered there, and we took care of the uninsured of the Conejo Valley in Ventura County. And I watched family medicine physicians and internal medicine physicians come to this clinic on a weekly basis and take care of the whole person. You know, people would walk in and this was their only source of care, and whatever it was that they brought to the table, we took care of it, and our doors were open. We got to know people over time. We got to know their families. And actually, when I go to clinic, it is those same principles of taking care of the whole person, knowing their context, taking care of them in the context of their lives, that keeps me really enjoying primary care.
I think it was exactly the same for me. I had the notoriety of being the only graduate of our HEMONC fellowship who got board certified in all three and then decided to go back and take a job in primary care. And I did that for one reason. I wanted to take care of the whole person and not just be the person prescribing the chemotherapy or the cancer-directed agents. But I think in reality, primary care falls short of that ideal. How do you experience that ideal of primary care that you felt in the free clinic and then being an attending primary care doctor practicing now?
It's a really good thing to reflect on, especially at certain points in your career. I will just say that there are certainly times when I feel that in my practice. I love getting to know my patients, their families, and taking care of the diversity of issues that come up for them. I am unsure that modern primary care is organized in exactly the right way to facilitate that kind of care. We are paid in large part on a fee-for-service basis. That means that we are paid for the care that happens in the exam room, and at most with the new E&M billing changes on a certain day. We have limited time with our patients, and so we can talk about one or two issues today, and that'll be it, and we'll talk about the rest next time. And then there are also barriers that come between us and our patients, including our availability, challenges with our patients navigating the healthcare system, which is often beyond our control, and also challenges with coverage of certain care that our patients might need. And while that may feel like it's, out of scope for any single physician, it reflects on us as a healthcare system and ultimately on the care we hope we are able to provide.
Can you define what do you mean by the new E&M codes?
Yes. So a change went into place in 2021 that enables you to bill for all of the time that it took to care for a patient on the day of the visit. So, for example, if I am spending 25 minutes with a patient on the day of their visit face to face, but then subsequently additional activities such as documentation or other coordination activities occur same day and they take longer, that can be part of the billing that takes place on that day. But the whole point of primary care is that we take care of patients every day. We don't just take care of patients on the day when they come to our office or when they are in front of us. And this leads us to the issue of the time that we all spend on the electronic health record. And so while those E&M coding changes were a substantial improvement, they still don't help us capture the work of primary care appropriately.
It's a good segue to move on to what is wrong with primary care. I might say it more strongly than you. I think you said I'm unsure if primary care has lived up to its expectations. I would say modern primary care does not live up to its expectations. And it's for reasons that have nothing to do with the people that went into primary care and provide primary care. I think it's a disappointment for clinicians and for patients. From the patient perspective, everybody intuits that it's not working the way it was, say, 10, 20 years ago. Patients really struggle to find primary care doctors at all. And if they can even get in with a primary care doctor, they find they can't get an appointment with the person that they built a relationship with and they know and they like. And then on the doctor side, doctors are burning out. They're going part-time. They're quitting in higher numbers now than they did before. In your view, what is the biggest problem or the biggest maybe top two problems in primary care? Why are all of these issues happening now and not, say, 10 years ago?
I would say that there are a couple of things contributing to the issue. So the first is one that I highlighted already. The way that our care delivery is financed in many instances really differs from the way that ideal primary care would be delivered. Our payment system is such that we are delivering care via widgets, individual sort of grains of primary care, when true primary care is best delivered continuously by a team who knows the patient over time. So I would say that that's one of the main issues. The second is we have to acknowledge that the scope of primary care has increased. We know that all of us as a society have gained more illnesses over time. We have accordingly gained more specialists. Our lives have become more complex. And there are some good things, but that have also resulted in different patterns of care delivery. We have new ways of communicating with our doctors. We can send them messages, we can send them pictures. And while some of that is good, it creates an unsustainable system for primary care delivery. So the systems that were delivering primary care 10, 20, 30 years ago are not the ones that can hold up the demands of modern primary care, both from the medical needs of the patients as well as the administrative demands of the system.
I want to talk about that unsustainable system. I wrote in a Substack piece that modern primary care is a design failure that's built on distorted math. And you capture that math so elegantly across many studies. And I will admit, I spent this Sunday, I kind of fell down the rabbit hole of reading all of your research. Not all, it was hard because you publish a lot. For me, there are two main pieces of that distorted math. One is the total patient volume in primary care. I think my cap at Stanford was about 15 or 1600, where you really can't get to know that many people. And I don't think any human mind can remember the details of that many people.
Yeah.
And then the second piece of it was the administrative work. I read this study from the University of Chicago that said if primary care doctors did everything they were meant to do in a day, we would be working 27-hour days. So let's talk about patient volume first. So, how many patients does a typical primary care doctor have today? Many of my patients are surprised. Were surprised when they realized how many patients they were competing against for those visits, and that's why my visit appointments, were so scarce. So how many patients does your typical primary care doctor have today, and what is driving that high number? Is it all fee for service, or is it something else?
It's a good question. So exactly as you stated, typical primary care panels can run from 1,800 patients to 2,000 patients to 2,500 patients. It varies by the market and it varies by complexity as well. We can talk a bit about ways to adjust for panel size, but this is one of those things that I am not sure has been updated. So these were the panel sizes of times past that have persisted, despite the fact that our patients have become sicker, have become more socially complex as well, and the work associated with their care has increased. And it's one of those numbers that is taken at face value and likely needs re-examination. And there are models in which, for example, if a primary care physician partners really closely with a nurse practitioner or physician assistant, they may be responsible for panel sizes even greater than those that we are discussing.
Let's unpack that second number, the 27-hour number. And I know you've done research that has given different numbers, but let's break it down a little bit before we get into what I call the fake math. um, what does a primary care doctor do in a day? So let's say you have 30 minutes with a patient, and it's a 70-year-old man that you've known for a couple of years with a few chronic comorbidities. Tell me, what are you doing in a day as a primary care doctor?
Yeah, so let's start with the visits, as you said. And one thing I'll emphasize is that it is important to me and to many other primary care doctors, I would argue to most primary care doctors, to first of all, find out what matters to the patient and what's on the patient's mind. And I will emphasize that that might not be the same list of things that are on my docket as a primary care physician. So somebody might come to me saying, my knee hurts, my throat hurts, my mood hasn't been great. Oh, my memory is changing. What should we do about that? Does that concern you? All of those things are important. Then we help manage chronic illness. We are able to manage a host of illnesses ranging from diabetes to hypertension to osteoporosis to kidney disease. You name it. We're trained in all of that, and we do that. We then provide preventive services. We are the ones who make sure that you are up to date on your colonoscopy, your mammography, that you have your pap smear. And I want to emphasize that the latter activities are not a check the box. They require medical decision making. I need to be able to think through what was the finding on your last colonoscopy and how does it influence the next time you'll have a colonoscopy? What was your last pap smear result? What does that mean for the next time you have a pap smear? We coordinate care with other specialists to figure out what is the best treatment plan for every patient. We document, and that means writing notes, both for ourselves, for our colleagues, so they know what has taken place, and increasingly for our patients as well, who read our notes. We write prescriptions. Oftentimes those prescriptions require authorization. We have to make the case that a patient needs a prescription to an insurance company. We can help patients get equipment that they need, whether it's wheelchairs or other supports at home. And that's just where it starts. That's on the day of a visit, for example, and the days after a visit. And then we take care of you between your visits too. And so if you message us to say you have a question, your blood pressure is high, something's not quite right, we want to be there for you in those times.
And I think that has been the crux of a lot of the issues in primary care is that what we call the asynchronous care. A lot happens between visits, and ideally, the primary care doctor is the one who knows you, can respond to any changes in your health, and be your first point of contact to help you navigate that. So, a lot of that comes through the electronic medical records. You've done a lot of research showing how much time primary care doctors spend on electronic medical records. I found one of your papers, it said you looked at clinics, I believe it was in Boston, and it was 36 minutes per patient visit spent on the charts when the visits themselves were 30 minutes. And then 6.2 minutes of those time were what we call in primary care colloquially pajama time, meaning after hours time. Tell us more about the burden of the electronic medical records on primary care doctors, and why is there so much work in the electronic medical records?
Before I dive into the problems with the electronic medical record, I want to emphasize that it's really not about the electronic medical record. It's about the system of care that it represents, because we actually know that electronic health records have made us safer. They have made it so that we can share information better, we can track clinical data better. And so all of that is good. The electronic medical record is in some way a reflection of our system, and we can track work in it. And so that's in some ways why we focus on it. But what I will say is that for we have data, multiple data sources showing that the burden of work in the electronic medical record, including the time we spend on documentation, on writing our notes, the time we spend corresponding with each other through the electronic medical record, answering patient messages, is disproportionately high for primary care physicians compared to other specialties. We also have information that some of that work is increasing over time, particularly for primary care physicians. So using national data, we showed that the volume of messages increased during the pandemic. The number of telephone calls increased and then came back down, but messages stayed high. And so in some ways, the pandemic gave us a new way of communicating with our patients that has persisted. Again, it's good. We have also shown in separate work that more time spent on the electronic inbox is associated with better outcomes. So of course, if you were writing back and forth to your doctor about your blood pressure, and the doctor saying, well, let's try this change to your blood pressure medicine, and you sort of iteratively write back and forth, it is good for people's health. We've shown a positive association between time spent on the electronic health record and patient outcomes. And yet that time is outside of the visit. It is uncompensated, and it's not very realistic for the panel of 1,800, 2,000, 2,500 patients that we talked about. The solution that we have also found in studies is strong teams. And I hope we will get to talk about that, because we've shown that the more that your teams can contribute to writing orders, helping you with messages, being a real partner, that is helpful for both reducing electronic health record burden and for a sense of PCP well-being. But again, the fee-for-service system of primary care, the predominantly fee-for-service system, often makes it hard to sustain those teams and engage them in work aside from delivering visits.
I promise we're going to get to solutions. This is not all bad. And we're going to talk about team-based care as well.
Yeah.
I wanted to lay out all of the problems first, because
Yeah.
I know my patients have been surprised when they learned some of these numbers. And again, even just reading your work, living it myself, it was dramatic to read some of these numbers. Getting back to patient messages, just the number of messages, like you get back to clinic on a Monday morning after the weekend, and I mean, I literally have about 100 things to sort through, in addition to seeing my patients who start first thing in the morning at 8 a.m. and my day is booked 8 a.m. to 5 p.m. I really want to emphasize this, that this is time outside of the visit and it's uncompensated time. And just like you mentioned, I think this is a good ideal to shoot for, that patients should be able to contact their doctors or their care team in between appointments, because so much of health happens in between appointments. But when all of this started, when messages opened up to patients, it was not thought out in the fee-for-service system where that time would come from, how it would be compensated. So in short, it just wasn't. It was just an expectation that was placed on primary care doctors. And I cited this line in my book that I want to read aloud, that compared to surgical colleagues, primary care clinicians received more than twice as many team-derived messages, 5 times as many patient messages, and 15 times as many prescription messages each day. And then you also found discrepancies among primary care doctors. For example, female physicians received significantly more messages than their male colleagues. So, why do you think the message volume is so high in primary care compared to other specialties?
It comes back to the comprehensiveness of primary care, the fact that we are able and in an ideal world would manage the wide diversity of chronic conditions that one might have, preventive care, and questions one might have. And I'll just emphasize this about patient messages because I think it's really important to understand when we talk about uncompensated time. These messages, in line with the work that we do, are not yes or no questions. They require independent clinical reasoning. So I might get a question about how someone is feeling or a test result from another specialist and how that fits in with the broader picture of their care. And so that takes time and skill and training, and we are well equipped for that. But it exactly as you stated, is in addition to the visit-based care we provide and is uncompensated. And messages are increasing because there is an increasing complexity of health information, coupled with the fact that there is this new way of communicating with physicians. I'll also emphasize that there are real access problems in primary care. Across the country, there are not enough primary care physicians. That is an acute problem in rural areas and in particular portions of the country. And so when you can't get in to see your PCP, when you can't get in a timely fashion, as anybody would, our patients ask those questions via the portal. And so the combination of the technology being available, the complexity of modern medical care, and issues with access all have driven up patient messages.
So it sounds a little bit like a vicious cycle where patients are having access problems because they're competing with, say, 2,000 other patients to get these coveted appointments. So they do the only thing that they think would be, a way to reach their doctor, totally reasonable, which is calling in or sending a message. And then the messaging is driving good physicians to burnout and driving good physicians out of primary care, which then worsens the access. You had this recent paper that came out that talked about what a full-time primary care job is, how many hours per week. And these numbers were really stunning to me, so I just want to read them. The median work hours for a full-time primary care doctor was 61.8 hours per week, not the intended 40 hours per week. And then part-time primary care doctors actually spent more time per patient on average than full-time primary care doctors, meaning my interpretation of that is that people go part-time to be able to do the work that primary care requires safely. That full-time primary care doctors are spending less time because they don't have the time, not because the work isn't there. What are your conclusions from this paper?
I hope we showed with data that primary care in its current design is not sustainable. The average panel sizes in the system that the study was conducted in were even smaller than those in an average system. And despite that, PCPs spent a median of 62 hours per week caring for their patients, with folks at the 90th percentile spending up to 89 hours. I think your interpretation of the patterns of time spent by part-time versus full-time physicians is exactly right. And what it reflects is that if we were doing care as we wanted to, if we were delivering care as we wanted to, we could spend even more time. And yet within the constraints of a full-time job, that is probably not realistic. But as you stated, we want to do the best by our patients. And so often that does mean cutting back. It means cutting back on salary. In some cases, it may mean cutting back on benefits so that we can devote the time that we feel is appropriate to delivering care to our patients. We also, in this study, were able to identify some factors associated with greater time expenditure that we hope can inform that total panel number that health systems expect of PCPs. We found that more medical advice request messages were associated with more time, a greater average age of the panel, a more medically complex patient panel, and more patients who had Medicaid insurance all were associated with more time. And I will say that as a practicing PCP, none of that is surprising to me, but we did this study so that we could have the data to drive change in a data-driven way, so that when health system leaders go back to the table and are wondering what they should set panel targets at, 2,000, 2,500 is likely not the right number. And we have identified the specific characteristics that are associated with more time.
Let's talk about solutions, but actually, just before we do that, we've already touched on this, but I really just want to lay out what the consequences of this, as you call it, an unsustainable system of primary care. What are the consequences for patients? What are the consequences for physicians?
Let's start with the physician consequences because I think that will help drive us towards the patient consequences. We know that primary care physicians have a greater likelihood of attrition, so leaving clinical practice completely, than those in non-primary care specialties or other specialties. We know that primary care physicians are also, or my team is doing a study demonstrating that primary care physicians are more likely to cut back on their clinical hours. Primary care physicians are more likely to burn out, and we know that a substantial proportion of the primary care workforce intends to reduce their hours or intends to leave the job. What does that mean for patients? It means that if you're having a hard time getting access to your primary care physician now, or any primary care physician, it's going to be worse in the future because primary care physicians will be in even shorter supply, and they may be less available even if they are still practicing. We also know on a system level that more primary care is associated with better outcomes. Primary care is associated with lower mortality. It's associated with better preventive care for the whole population. And so ultimately what these trends mean for patients is that we will have less access to care, and it may have real implications for our health.
Everybody needs a primary care physician. I am a primary care physician and I can't access my own primary care physician. I can't even access myself when I tried to make an appointment with myself on the patient portal.
Oh, wow.
I had said that I was booking 3 months out, so no appointments were available, and I thought that was pretty funny and ironic and sad. Let's get into solutions. And broadly, the way that I bucket them, I call them the 3 T's just because it's easy to remember: tech, team, and time. I want to actually start with time. We've talked a lot already about fee for service and the time that you get in a patient visit, the time you get for all the asynchronous care does not match what the needs of patients in primary care are. Do you think fee for service is just a non-starter in modern primary care?
I don't think it's the long-term solution for how we finance primary care. I cannot tell you that I have the exact solution for how we finance primary care, but it is certainly not on a widget basis, the widgets that are encouraged by fee-for-service medicine.
What are your thoughts about capitation? So insurance paying per patient per month so that patients have access, ideally, to everything they need within primary care, not the widget assembly line model of patients being paid just by the visit.
I think it is the right high-level approach, and then the devil is in the details. So from a big picture perspective, that type of payment would allow physicians to care for patients in the way that seems right for them. Whether that's asynchronously over the phone, bringing patients in, having other team members care for patients, that type of payment would enable flexibility in care, such that ideally patients are getting care in the way that is best for them. And our healthcare field has been humbled, and we know that implementation of capitation has been challenging over time, partially because of rising healthcare costs and partially because of our challenges estimating how complex our patients are in exactly the right way, such that the amount that is paid for a patient is exactly right in order to compensate for the care they really need. So broadly, I think it is the answer, and I will say that it is complex. It is much more complex than me saying that it is exactly the right approach. The other thing that I'll note that's really important is that we know that there's a critical threshold. Now, there isn't a specific number for this, but for that balance between fee-for-service medicine and paying for a panel of patients in terms of how PCPs are able to conduct their daily business and then staff their teams for this daily business. And what I mean is that as healthcare systems have experimented with value-based care or providing a certain level of funding to care for a panel of patients, oftentimes with additional incentives for quality of care or other utilization measures. PCPs and their teams may be stuck between the incentives of fee-for-service medicine, so seeing more patients in order to generate revenue, and caring for patients as part of a set amount of funding. And really, the value-based care works best when incentives are more aligned. Oftentimes, that means that more than 50% of primary care revenue is coming from value-based care. But I just want to highlight that nuance because that foot in two canoes has been really challenging for primary care in recent years.
And I think what you hit on is really, really important. There's a lot of guesswork involved in what goes into modern medicine, like the idea, even initially, of fee for service, like the guesswork of how many minutes does it take to provide a visit? How many minutes does it take per year to take care of all of these patients? How many patients should a full practice be? And then at the same time in value-based care, the guesswork involved of how to adjust for complexity of that patient panel, and the amount of time that physicians will need to spend on those patients in order to take care of them properly, which makes it very challenging, even if, as you said, I think directionally correct, which does lead to team-based care. So ideally, in a value-based or capitation model, when you get paid per patient per month, you have the funding to spend the money on whatever you think as a primary care practice is needed to best take care of patients. And many roads lead to team-based care. What do you think the ideal team in primary care looks like? Because I think there's still this old-fashioned image, one doctor, one patient, which isn't really the case anymore.
One thing I'll emphasize before I go into the technicalities of who the members of an ideal primary care team are, is that we've actually shown through qualitative interviews that the best team is a stable team. So I'll just go on a little bit of a sidebar and then I will answer your question from a primary care perspective. We've talked about the challenges of primary care in the modern healthcare system for physicians, but we know that there are also challenges for other members of the workforce. There are high rates of intent to leave and intent to reduce hours among nurses, for example, among medical assistants. And so I will just emphasize that as we are thinking particularly about team-based solutions, it's really critical for us to think about the experiences of these other team members because they are important. And because we know that even separate from the exact roles, stable teams are really critical. Okay, now that I've gone on that sidebar, let me talk about what teams can be helpful in primary care. So you can think about the most standard team one could envision. Perhaps the physician works with a nurse. Perhaps the physician works with a medical assistant who helps room patients take their vitals while the nurse answers phone calls, provides patient education, administers vaccines. That team can include the staff that are helping patients make appointments and helping them with administrative issues. But there's also evidence that the teams of primary care benefit from additional role types that may be unique. So, for example, and this is the way I trained, and it made such a difference for my patients, pharmacists have a critical role to play on the primary care team in terms of managing chronic conditions, titrating medication. Behavioral health specialists have a critical role, whether that's a social worker to help patients with both some of their mental health issues as well as some of the social needs they may experience that I frankly just don't have expertise in managing. We know community health workers can be really critical for certain populations of patients that are seeking to navigate complex systems and complex lives. And that's really just the beginning. And so one thing I'll emphasize is, as you alluded to, the model of the all-knowing physician is just not realistic in this day and age. We are not all-knowing. We do not have all of the skills. And our patients greatly benefit from us having team members to help tackle all of the tasks that are part of that 27-hour workday that you cited.
It's interesting from that same paper, the 27-hour workday, they modeled that with team-based care, the workday was 9.3 hours. So dramatic difference. It was still above an 8-hour workday, but it was much closer. So I think what you are alluding to is just getting the work to the right level of care. And my experience in training was that we had that team much more in the hospital setting than in the outpatient setting in primary care. I remember in residency rounding on patients, and there was always the bedside nurse was with us. There was a pharmacist with us, and having that team all there, co-located in real time, was incredibly, incredibly helpful to be able to provide comprehensive care for patients when they were sick in the hospital. And that just wasn't really my experience in the outpatient setting. You said a stable team is the best team, which I love. How do we incentivize continuity with team-based care? There's a lot of attrition, like you mentioned, not just among physicians, but of other team members. And it can be kind of like this revolving door of team members where a medical assistant is there for a year and then they leave and then you hire somebody else. And I will say my experience in modern primary care is that continuity of the team is deprioritized, that it is sort of assumed that people are interchangeable. And as long as you have, quote unquote, a medical assistant, right, or a nurse helping out, it's the same as having the same medical assistant who knows that patient panel, just like you as the primary care doctor know your patient panel. What are your thoughts on how we can incentivize continuity among different members of the team?
What I'll say is that there are culture aspects that influence anybody's experience of the workplace. And I spent part of my research career studying this. We know that what influences burnout among physicians, but among many others, is the culture in a particular environment, the culture of safety, the culture of support for what is going on in somebody else's life outside of the workplace, the culture of feeling supported in their growth. All of those are critical, yes, for physicians, but for these other team members that we're talking about. Similarly, sustainable work is critical for these other team members as well. The one piece I'll highlight that is probably a little bit different is that some of these team members are paid probably not quite what they deserve. And so that has to be a part of the conversation if we want stable teams. We know that in some healthcare markets, folks will change jobs to make an hour or two more or a dollar or two more an hour. And that is a really reasonable choice based on their life circumstances. And so there's one set of solutions that has to do with the basics of keeping people happy in their work. And for certain team members, there's probably another set of solutions that has to do with economics.
I would be remiss if I did not bring up AI being piloted as a solution in many places to respond to patient messages. What are your thoughts?
Well, it's interesting. If you had asked me a year ago, I would have been really excited about it. Let's say 2 years ago. And the data have just really not borne out. If you look at health systems across the country, they are not using this technology to a great extent, partially because physicians aren't using the technology. They're presented with drafts of messages, and then they don't end up using those drafts. So why is that the case? I think it comes back to what we were talking about earlier. The work we do is complex. When we answer a patient message, it's not a yes or a no. Oftentimes those messages via inbox pooling are already filtered from us. And when I say inbox pooling, I mean that many health systems have put into place interventions where before the messages get to the physicians, they go to a general pool, whether it's of medical assistants or of licensed vocational nurses or admin staff, who sort of peel off the messages that could be answered by somebody else. And so what gets to us is really the questions meant for a physician. And when those questions get to us, AI just does not seem to have been able to help us very much because the questions require medical knowledge. They require some sense of the patient's background that may be difficult to assess fully via AI methods. And one of the other things that we've heard that I find really interesting and gets back to this relationship point is people tell us the messages, or physicians tell us that the messages don't sound like them. And so the patient would know that they were using AI, and they don't want that. They still want that relationship with the patient via the message. So I would say it's one of the technologies that I think had a lot of promise and is not quite bearing out. And that doesn't mean it won't work completely. I know many health systems are testing it in different environments. So, for example, seeing if it's more helpful for front desk staff or for nursing staff. But for physicians themselves, it has not been as helpful as we've expected.
That completely jives with my experience. So this was piloted at Stanford, and I frequently read the AI generated drafts and I don't use them. My perspective, even from the beginning, was a little bit more pessimistic than perhaps yours, which is that I do feel like there's a lot of best use cases for AI in medicine, but impersonating me to answer messages was not one of them. And in particular, it just misses the point, right? These messages being uncompensated time, it's not bought out, it's not paid for. It just doesn't get to the heart of the issue, which is there's this huge volume of messages, and physicians need time. They need time and compensation to recognize the complexity that patient messages is it's like a patient visit. It's
Yes,
work that a
exactly.
physician needs to do, not AI. And I think I'm gonna quote back to you, you wrote in a perspective piece here that large language model based responses may be best suited for protocoled replies. In contrast, they seemed less helpful in addressing queries that deviated from protocols or required nuanced expertise, which I think is perfect because nuanced expertise is exactly what primary care physicians should be doing. What about using AI elsewhere in primary care? For example, as more of a triage assistant. So when all of those messages or calls first come in, rather than answering the medical complexity part of the message, helping to decide, okay, does this person need an appointment? Does this person need a phone call? Who should be responding to this? Can it be triaged to the nurse and not the primary care physician? Because a big problem with patient messages is ideally we should be getting just the complex patient messages, but I think your experience is probably similar to mine that you are doing some of that triage yourself and things do just end up in your inbox that could be best handled either by an appointment or by a different member of the team. So what are your thoughts about using AI to help triage these messages and asynchronous work?
I think it's a possibility, and I have not seen enough data to make a strong statement one way or another. It is definitely a possibility, and maybe it won't directly affect us as physicians, maybe it will, but perhaps it'll free up a nurse who is triaging that message to interact with our patients in another way that advances the work of the team that we were talking about. So I have to see more data on that before I have a strong opinion. But one area that I think we have good data on is actually AI scribes, which I'd love to bring up. Some of the data coming out about AI scribes is fascinating. We have data showing, like others, that AI scribes help save some time on documentation. They don't really save time on work outside of working hours. And our hypothesis for that is we just have so much work as primary care physicians that when we save a couple of minutes on notes, we just answer the next inbox message. But physicians are happier. And I think it helps us come full circle to what we had talked about at the beginning, that we went into this for relationships. And what we're hearing from folks, and now we're trying to study quantitatively, is that even if the AI doesn't save them a huge amount of time, it helps them look at their patients and pay attention to their patients and feel that relationship in a way that they may not have previously. And perhaps it does not solve the time issues we have been talking about all along, but it helps us get back to the heart of medicine. So at least we're doing more of what we went into this profession for, which is talking to patients and helping them troubleshoot rather than taking notes, for example.
Yeah, I agree with that. In my view, the AI scribes sort of replaced the virtual scribes, which were hard for everybody to
Yeah.
obtain previously. And even if they don't necessarily decrease the time that you spent on the note, the importance of sitting in an exam room and making eye contact with a patient, that lost art, is such an important thing for both patients and for doctors. So I do want to also ask you about, I think all the rage now is this concept of direct primary care. I know people who have left traditional primary care to do direct primary care. And the way I'll define it is that it is similar to concierge medicine in that patients are paying a monthly or annual fee like they're going to a gym membership. But for concierge, they take insurance, and direct primary care tries to cut out that middleman so that patients are paying directly for their doctor. And it lets direct primary care physicians cap at around 200 or 300 patients instead of 2,000 patients. What are your general thoughts about direct primary care? And I think the bigger question is there a path to that level of access and relationship-based primary care for everyone without catering to patients that are able to pay that monthly or annual fee?
I'm glad you brought this up because it is, as you said, a point of great discussion. I want the answer to be yes, because we want to be able to take care of 200 or 300 patients really well. And I think it comes down to the question, the exact question you raised of, is there a way to make this scalable so that it's available even to those for whom that monthly fee would be a real barrier? Can this model be scaled in a way such that we are not creating disparities? I just don't know the economic answer to that question, but I would love for the answer to be yes.
Overall, given everything that we've talked about, how hopeful are you that we can implement these solutions in primary care? So I think some are already being implemented, like the AI scribes. Others, like hiring more members of the team in different settings. And I think fundamentally, we talked a lot about payment models and fee for service and capitation and the nuances involved in implementing the right payment system that would let primary care physicians see the right number of patients and not carry so much extra work home with them. How hopeful are you that we can make these changes? And I think a separate question is who decides, right? Like, who needs to listen to this interview to implement these changes?
I am hopeful. I am hopeful because we're talking about this and I hear increasing discussion of this topic. I'm also hopeful because we have seen recent policy changes that are at least pointing us in the right direction. They started from the E&M coding changes in 2021, which, as we discussed, are a step in the right direction, even if they continue to have limitations. There have been new policies about advanced primary care codes that um, would enable practices to receive extra payments for taking care of populations of patients in with team-based support, particularly for those who have chronic conditions. So all of that is moving in the right direction. What I think we fundamentally need to agree on, beyond you or me, who already believe in this, is the value of primary care, not just for the relationships, although I think the relationships are critically important, but for the value of primary care on outcomes, because we may need to make hard decisions in that there are limited resources in any environment, in any healthcare system, and we certainly face that in the United States. And so it may take hard decisions in terms of resource allocation or relative pay or relative resourcing in order to truly make primary care better. And for that, I think we need an increasing alignment on the economic value of primary care and, frankly, patients to raise their voices about the value of primary care. When primary care is really good, how it makes a difference for people.
Before I get to the last question, I will share a brief story. When I started out, I was taking care of, like I mentioned, it was something like 1,500 to 1,600 patients. And while I loved being able to provide comprehensive care for each person, I didn't have the memory, to take care of, to remember all the details about 1,500 patients. And I remember
Of course.
walking out in the elevator one day, and there was this woman. It was during COVID, so she was wearing a mask, but I don't think this was the reason that she started thanking me profusely and basically saying I saved her life. And
Wow.
she was telling me, like, it was so, she was so grateful. And for the life of me, I have to admit, I didn't know who she was. I didn't know what I did for her. I tried to guess based on, I didn't want to admit that. That would have been horrible. And I just tried to guess based on then how she continued the conversation. And I think for me, that really captured just what the value of primary care is, as well as the constraints of primary care. So, Dr. Lisa Rotenstein, can primary care be saved?
I think it can be. And it will very likely not look, when it is saved, it will not look the way it does today. It may not look like folks coming to our office for 20-minute visits. It may look like us taking care of them on the phone via message with the help of our other team members. It will likely be paid differently. The extent to which physicians will continue to have the same role they do in primary care versus partnering with nurse practitioners or advanced practice providers to provide primary care. I think the value of primary care is undeniable when you feel it and you see it. And we need to do a better job of raising our voices, helping patients raise their voices. So at least the conversation continues and we are able to test out solutions until we find what is right and what will save primary care.
Dr. Lisa Rotenstein, thank you so much for joining Hard Medicine.
Thank you for a great conversation.
Thank you to founding member Matthew Beckman. If this conversation helped you see medicine differently, subscribe to Hard Medicine and share this episode with someone who should be part of the conversation.